All right, so I caught you guys yesterday when you guys were like in some stages of narco-sleepy. So hopefully I got you a little bit more energy level today, right?
Yes.
All right. Yes, good. So I always start every class, like I told you guys yesterday, not before, because it was the first time, right? That I asked you guys at the beginning of every class, do we have any issues? Do we have any problems? Do we have any concerns? And that's just to get a pulse check, right? To see where we're at, just make sure we're all progressing. Because as you guys know, every lecture builds on the next lecture, builds on the next lecture. When's your first test? Friday the 26th? Yeah. Sorry? Not Black Friday, just Friday the 26th. Right? So I want to make sure we're keeping up to date with where we're at. Okay, I used to give quizzes. The feedback I got, they weren't very helpful. Okay? So in contrast to quizzes, I'm going to just do, at the beginning of every lecture, after I ask you guys how we're doing, I'm just going to do kind of a review, okay? And just see where we're at. Just make sure that we're all progressing so we don't hit the next milestone and we're still lagging behind. Does that sound fair? Okay, now getting to that fairness, I was a little bit beat up yesterday myself. I told you I've been dealing with a house flood. So, and one thing I didn't mention is that for me, I have 3 principles that I live my instructor life by, okay? First one is respect, the second one is integrity, and the third one is fairness, okay? So if you understand that about me, that tells you everything you need to know. I will respect you guys, I will respect your time, I will make sure that I try to utilize class time, that way you're not trying to do a bunch of stuff on quote-unquote your own time, okay? And you'll get to see what that looks like when we get to the first lab. Okay, integrity, if I tell you I'm gonna do something, I expect you to hold me to that, okay? If I tell you I owe you something, I'm gonna do something for you, I will do it. If I forget, I'm in the 5th decade of my life, so I do forget things. My wife reminds me every day. So keep me in check as well, okay? And then fairness, I keep telling you guys about tests, right? How I'm gonna test, right? What I'm looking for, what I think is fair as far as testable material. So keep asking those questions because then you'll get a sense of, again, where I'm at as far as what you can expect with how I test, okay? I told you yesterday that, excuse me, when it comes to physical exams, orthopedics is physical exams. So if you do not spend time learning and studying and practicing your physical exams, you may not successfully navigate this course, okay? You may pass, but I'm just saying, I will tell you that the slides, I did my best to prepare slides for you guys that give you the meat, right? But maybe not the potatoes. Okay, so I want you guys to dig into the physical exams. Did anybody go to look at the syllabus yesterday and see that there's a physical exam book listed in the syllabus? That book is also found in the university library system. Okay, so you should have access to that. Same thing with the textbook, okay? Any questions about anything I just said? How are we doing? Good? Okay, we're all frosty? We're good?
Yes.
Okay, awesome. Yes, I want participation, okay? Let's keep this fun, let's keep it lively, and let's learn. Ortho's the best. All right, so yesterday when I stopped lecturing, I did kind of mention the spondy thing. Spondylo, right? It's a Greek root word, English. And so this is an area that I wanted to kind of review real quick and just let you guys, this slide is on your Canvas page. I uploaded it, okay? That way you didn't have to re-download the entire slide presentation. It's just this one slide. This is like a supplemental slide, if you will, okay? This breaks it down. Spondylo, right? It literally refers to pertaining to the spine or the vertebrae. But what students commonly get wrong is once you get past that spondylo, what is the last part of it, okay? So if you look at spondylosis, I was telling you guys yesterday, spondylosis is degenerative, right? So that's the arthritis component of it, the osteoarthritis component of it, okay? When we talk about spondylitis, anytime we talk about an itis, like we mentioned yesterday, that is inflammation, right? So spondylitis is an inflammation of the spine. Do you think that could be related to infection or autoimmune processes? Yes, and we'll get into that stuff. And then spondylolisthesis, I did mention that this listhesis portion of it is where the vertebrae slips forward, and we'll get into that as well. Okay, but I want you to reference this slide as we push forward so you can keep these things straight in your mind. And then the spondylolysis, right? That spondylolysis, the lysis component of it refers to a break or a crack in the vertebrae. We go with that?
Sir.
Okay, so this is something I want you guys to commonly reference, because if you go to the textbook, it gets into it, but I just want to make sure again that I'm fair to you guys and give you some references and some resources to keep things straight in your mind, okay? If you're doing your worksheets, you'll see these as well. Good to go? Okay, so a little bit of review from yesterday. So when we talked yesterday about getting a good history and getting a good physical exam, we initially started talking about the snack, crackle, pop, right? So that's that where you're going to ask the patient, like, what kind of symptoms are you experiencing? Can you describe them more for me? Make sure you're also asking questions like instability versus weakness, right? And when we get into our special testing, you'll see that a lot of those special tests, are actually not checking for pain. They're checking for instability and or weakness. Okay, so keep that in your mind as we progress forward. Okay? I told you guys yesterday that anytime you start a physical exam, you want to ask the patient with one finger of one hand, usually the unaffected side, right? If it's the shoulder, for example, point to me where it hurts you the most. That'll help you zero in and focus in on your exam and on what you think that the diagnosis is and the potential differential diagnoses, okay? So keep that in mind. Good to go? Another thing we talked about yesterday was a CMC grind test. That's the first one that I gave to you guys. Okay, so if you're given a clinical scenario or a vignette, like on a physical exam, on a end of course exam, and those components are given to you, that'll be described to you. Okay, makes sense? And just try to compartmentalize those as we go and rack and stack those so you know how they differ. Okay, good to go? Okay, stop me if you need to. So types of fractures, I didn't really get too far into it with the types of fractures. That was more of a reference slide, because again, in the next block, we talk more about fractures, specific fractures, and then in the fourth block, you really get into fractures. Okay, if you look at your syllabus, you'll see what I'm talking about. We talk about specific upper extremity fractures, specific lower extremity fractures. The one thing we do talk about in this block is spinal fractures to a certain extent, okay? But again, you get into it more so in block 4. Okay, so keep that slide as a reference. You guys know which one I'm talking about? The one that had all the words on the side. Okay, just keep that in your mind and just kind of start looking at that and prepare yourself mentally for all those different fracture patterns once you get into block 4. Okay, open versus closed fractures. I will tell you right now, if you have an open fracture and you don't call surgery, you're not doing what's best for the patient, right? So anytime you're doing a clinical scenario, like a test, for example, pants, they give you an open fracture, you just look for the answer that says referral, right? Or surgical intervention, one of those two. Make sense? So just keep that in mind, because a lot of closed fractures can be treated non-operatively. Which leads me to my next point, is that one thing that I learned last semester in talking to students was that people think that operative literally means you refer to us, okay? Now, that's not wrong. Orthopedic surgery, yeah, you'll refer to orthopedic surgery for fractures, potentially for surgical consideration. But then if we see them and we decide, hey, we're either not gonna do surgery now, or we're gonna try to not do surgery for a while and just watch the fracture and see if it heals, that's also non-operative management. Does that make sense? So when you're looking at your slide and you see the word non-operative management, it doesn't necessarily mean that you're managing them. When you're referring to us, we may also be managing them non-operatively, but now they're in the surgical arena. Everybody understand that differentiation? Okay, because I know that was a point last semester that was kind of like, wasn't clear. The book doesn't really get into it either, so there's a lot of fault there, okay? So just so you go, just because you refer somebody to me, right, and I see the patient, and I can see the fracture, you can see the fracture, I may actually do a little something, right? I like to crank on people and make it look straighter, right? Put it into a splint, watch it for a week or two, see if it starts to heal, doesn't move, and then we're like, okay, no surgery. Or in that, after 2 weeks, we're like, it's just moved too much, it doesn't look like it's gonna stay, and then we do surgery. Does that make sense? Were those closed fractures or open fractures?
Open.
Closed, right? If they're open fractures, we're gonna do the business. That's why I love open fractures. Okay, so, any questions about that? Okay, so loss, we talked about that yesterday. Like, remember, that's something that's gonna be a recurring theme. Okay, so the L stands for, somebody from this side? Loss of joint space, right? So joint space narrowing. The O stands for, okay, bone spurs, right? The first S stands for sclerosis, those white stripes, that white hyperdefinition, right, on the articular surface, right, the bone surface on the articular side, okay? What does the other S stand for? Subchondral cyst. So subchondral meaning it's underneath the cartilage, and there's cystic formations. Good to go? Okay, that's something you're gonna see over and over again. If you get a spinal injury concern, any spinal injury concern, whether it be fracture, whether it be infection, what have you, as far as the cause, right, the root cause, what are the key things you guys are gonna do again? Neuro exam and gait, right? Okay, good. So we're on the same page with that. Right, and then something I want to preface today, and kind of like do a primer, if you will. You guys have heard this before, but when we talk about specificity and sensitivity, we're going to start talking some stuff about some labs today, okay? So when we talk about specificity is one of those things where when we're talking about the difference between specificity and sensitivity, is that specificity is true negatives, right? It's kind of a weird way to think about it, but specificity tells us who doesn't have it, right? And sensitivity is true positive, which tells us who does have it. Okay, so a good test rules out the people that don't have it, and then the people that do have it. Does that make sense? Okay, so not every test has specificity and sensitivity. And as we go through today, if that point becomes unclear, I want you guys to ask those questions, okay? Because that is stuff you're gonna start seeing in some exams, okay? And you're gonna see it on pants. So if something is highly specific, is it also highly sensitive? It could be, but not necessarily so. That's why there's a differentiation there. So I want you guys to think about that as we go through these disease processes, okay? Any questions about that? Okay. All right, so we're gonna start. Today we're gonna cover RA, so that's osteoarthritis, semicolon rheumatoid arthritis. Okay, it's a different kind of arthritis, semicolon rheumatoid arthritis. So that's a different kind of arthritis. Is it still inflammation of a joint? Yes, but it's due to a completely different process. Okay, so think about that as we go through it. Seronegative spondyloarthropathies. Okay, seronegative meaning serum, right? Seronegative. So you did blood work and it's negative. We'll talk about those specific labs as we go, but there's the word spondylo. So referring to what again? The spine of the vertebrae, okay? Arth referring to joints, and pathes referring to disease processes, okay? We're going to talk about compartment syndrome. The beauty of orthopedics, especially if you don't work in trauma, is that there's really only like 3 or 4 surgical emergencies in orthopedics. Compartment syndrome is one of them, okay? So this is something that you guys will see again, need to know, focus in on it, okay? Because you will see it again in EMED, you'll see it in surgery, you'll see it spans the multiple subjects, okay? We're going to talk about complex regional pain syndrome. Yes, you're going to hate that diagnosis, I promise you, but because it's challenging to treat, okay, even at the surgical level. We'll get into that. Crystalline deposition diseases. You guys talked a little bit in pathology already, right? About gout, pseudo-gout, things like that. So we're going to get into a little bit more from the specifically ortho concerns. Okay, and then we're going to talk about DVTs. Okay, so RA, rheumatoid arthritis. It helps if you turn it on. So when we talk about rheumatoid arthritis, so this is where we start talking about, is this degenerative or is this a systemic inflammatory process? Systemic inflammatory process, okay? Now this is really confusing, I get it, okay? But believe it or not, in the world of orthopedics, osteoarthritis is classified as non-inflammatory, right? Because it's not an inflammatory process in the sense that there's a systemic disease that's occurring that's causing it. Okay, do you have inflammation with osteoarthritis? Yes, right? But that's a symptom, not a cause. Does that point make sense? Okay, so RA, rheumatoid arthritis, is an inflammatory arthritis. Okay? So if you think about it, then if some disease process is causing the inflammation, then where is it? So it's acute, and chronic synovial inflammation. So everybody knows that there's a synovium capsules around the joints, right? Fingers, wrists, your knee has one too, right? It's a big one, okay? So there's inflammation in there, and that inflammation can lead to erosion and other destructive processes, okay? And that's where it says right there, it's erosion where the joint capsule meets the bone. The incidence of it is, for women, is 3 to 1, okay? So women have it 3 times to 1 time males, okay? So when you start looking at these clinical scenarios, you start thinking to yourself, what is this scenario describing to me, okay? Late 40s is the peak onset, can be also early 50s. So you're given a pan scenario, it gives you this history of a 48-year-old female, okay? And all of a sudden they're having symmetric inflammation of their joints. You start thinking RA, okay? Because this is systemic, like it says right there, it's typically symmetric. Meaning if they have it on one side, they have it on the other side, and it tends to happen medial and lateral and left to right. Okay, so what do I mean by that? I mean, it can be both wrists, for example, okay? That's how it differs from osteoarthritis. So again, when you guys are looking at these scenarios, you start thinking to yourself, can you have osteoarthritis of both wrists? Absolutely. But what was the most common cause of arthritis in the wrist? Post-traumatic, okay? So if they only had a fall, but they had one side get injured, right? That leads more towards post-traumatic arthritis. But if they're a 48-year-old female, and they're having bilateral wrist inflammation, right? Bilateral hand pain, are you thinking post-traumatic? No, right? Not really, I like that. So it typically tends to, again, involve hands, wrists, knees, and feet. Did I say anything about hips and shoulders? Nope, I didn't. So again, when you guys start breaking down these topics, start thinking about them and how they occur, what type of patients they occur in. That way you can start focusing in on what you think is more likely. Okay, you guys see that picture up on the top there? Do you guys need me to turn the light off, or can you see it? You can see it? Okay. If you need me to turn the light off, just tell me. But when you look at those pictures there, you see if you progress from left to right, you see that erosion there, okay? And if you see that erosion there, when you get to the picture on the right, then you can see it's bone on bone, right? You see that redness there? That's supposed to denote the inflammation, okay? So once you get to that point, do you think it's super painful? Yeah, absolutely. So this is another thing that the patients will tell you. They'll tell you it's, again, 48-year-old female, all of a sudden they started having bilateral wrist pain. Over the years, it's gotten worse. You see what I'm getting at? It builds on itself, okay? And those pictures down there, again, I'm not gonna give you scope pictures on exams, okay? But those are scope pictures showing you angry, inflamed, just, this looks angry to me. Okay, you see that redness there? How it looks angry? Yeah, that's a pissed off joint, okay? And that could be a microscopic area too. These things are magnified, right? So if you're doing a wrist scope, these things could be super magnified. Okay. Any questions about RA intro definition? Okay, so clinical symptoms. So this is how it differs too from arthritis, is that they have pain, morning stiffness, swelling, and systemic symptoms are common. Okay, in osteoarthritis, normally you wake up like I did this morning, right after moving furniture to a storage unit for 3 days, and I'm like, dang, my body hurts. But then as I move, I get better. Do people with RA necessarily get better? No, it's an inflammatory process, right? So it's not degenerative. So joints of the hands and feet are usually affected first, so that's kind of your telltale. It's almost like hey, I'm an RA, this is RA, right? It started in my hands and feet, but now I can move on to what other joints? Knees, and sometimes feet. Okay, good. So it's a proximal joint involvement occurs later in the disease course. The DIP joints are spared. Okay, the DIP joints of the hand are spared. I would underline that, I would star it, I would do something. Okay, because the DIP joints are spared. And we'll get into the presentation of the hand and the wrist in relation to RA here in a second. 20 to 50% of patients have central and axial joint involvement. So what does that tell you? Well, central means down the midline, right? Atlantoaxial refers to what? The first two vertebrae, that is correct, thank you. So C1 and C2, right? So they have erosion of the odontoid ligaments, and therefore that axis now, right, the atlas that's rotating on the axis is unstable, okay? Why is that important? Right, so if you call me on the phone and you tell me you have a patient with RA who sustained a forearm fracture, I'm gonna ask you, hey, can you get some neck x-rays for me? We're gonna potentially take this patient to surgery. And then you're gonna say, potentially, well, not after this course, right? Because you guys are gonna be astute clinicians by then. Well, you're gonna say, well, somebody might say to me, well, why would you wanna get x-rays of the neck if you're gonna do forearm surgery? What position do we put them in to intubate them? Sniffing position, right? Up like that. So we wanna know, can they tolerate that based on their atlantoaxial instability? If they have atlantoaxial instability, their choice of anesthesia may differ. Make sense? Okay? That's a little pearl for you guys. Is that testable? No. But I'm just letting you know why that's on this slide, okay? This is a chart. Have you guys seen this before? Probably, maybe. You blinked twice and moved on with your lives. Okay? Am I gonna test you on this? No. It's just out there for your information. Look at it. These are the classification systems. You'll talk more about this in other classes. Maybe when you go in your internal medicine rotation, you'll start talking about this, right? But this is how it's classified, essentially. All right? Is this how orthopedics classifies it? No. What's the college that's written up there? Rheumatology, right? So this is how rheumatologists classify it. But this gives you some insight into why they may want you to get some lab work, want you to get some imaging, want you to do certain things before you refer to them. Make sense? Because we all have gotten into referral guidelines by now, right? You guys understand the concept of you can't just send people wherever you want. The clinical subspecialties will say, hey, before you send us a patient, you need to work them up. Well, this is an insight into how rheumatologists work up patients with RA. Good to go? Any questions about this long, winding chart? Okay, excellent. So clinical symptoms, again, what are the things that go with it? Anemia's on there. Can anemia go with a bunch of different things? Absolutely 100%. Okay? Then generalized malaise is on there. I have generalized malaise this morning myself, so I don't think I have RA. Fatigue, I have that as well. Don't think I have RA though. But then we start getting into like vasculitis, scleritis, all these systemic itises, right? These are other body parts, other systemic manifestations. So does this lead us down that road to start thinking that this, again, is a systemic inflammatory process? 100%. Pleural pericarditis, ooh, say that 20 times fast, right? Renal disease, right? So the kidneys may not be working, functioning like normal. And that comes into play when we start talking about medication selection, correct? The answer is yes, okay? So the big thing for orthopedics is that, we get referred, yes, the patients have pain, but we usually get the referrals when people have loss of motion, significant loss of motion. They cannot do the workplace sleep stuff that we talked about yesterday. So it's a loss of function and or the ability to ambulate. Okay, so not everything comes to us. Again, RA is thrown in here. How many times do I see RA in my clinic?
Occasionally.
Not much, okay? Because I'm like, well, what's your surgical question, sir, ma'am? And you're like, nothing, I just want you to see the patient. It's like, well, then you go see a rheumatologist. Because we're the surgery people, right? So that we look at a joint, like the hand, for example. I told you guys you can do an arthroplasty on hands, right? We can do arthrodesis on fingers too, right? So we say, well, maybe we'll do some of that stuff and get them to restore some function. Okay, makes sense? That's kind of where orthopedics plays into this. All right, this is a slide that you will burn into your brain because that denotes the position you're going to find RA hands and wrists, excuse me. So when we're talking about RA, we're talking about pain, swelling of the affected joints, diminished range of motion, synovial hypertrophy. So what is that hypertrophy? That's that boggy joints. Okay, so if you get a description in a clinical scenario, a vignette that says that the patient has boggy joints, what does that mean?
Spongy feeling?
It's squishy. Yeah, I love it. Yeah, I got the same answer 2 semesters in a row. That's good. So it's basically a squishy, okay? It's not an effusion though, right? Because there's no erythema, there's no warp necessarily. There's more inflammation and degeneration than there is effusion. Does that make sense to everybody? Okay, that's how it's different. That's why they're called boggy joints and not effusion joints. Okay? Now the deformity. Highlight this, burn it into your brain. Wrist radial deviation, finger ulnar deviation. When we get into upper extremity next term, I'm going to tell you guys, please don't use the terms medial and lateral. Because medial and lateral means that you have to have the patient standing like this, or you have to reference the patient standing like this, right? So when you look at your hand, right now, if you were to look at your hand, do you look at it like this, or do you look at it like this, and then go like this, and then look at your hand way up there, right? So start you thinking of things in the terms of radial. You guys know which side the radius is on, right?
Yes.
And ulnar when it comes to upper extremities. Go ahead and start thinking like that, okay? Because then you get it right. You don't have to be like, wait, what was that again? And then you guys will stand up in the middle of the exam and do this, right? It's like, if you want to do that, it's fine. Just don't look at other people's computers. But radial deviation of the wrists and ulnar deviation of the fingers. So that tells you right there. If you take your hand, put it up in front of your face, the wrists are going to go inwards like this, so radial deviation, and the fingers are going to go like this, right? Everybody do it? Do it to your neighbor. Okay, but so that's why it's important to understand what I'm describing to you, because if you don't, you'll get it wrong, because it'll be described to you. You'll get different options. Do you think it's going to say ulnar deviation of a wrist as an option? Of course it will. All right, come on, right? So you need to understand those differences. That's why I'm trying to prime you guys to start thinking of wrists, hands, upper extremities as radial versus ulnar, and not medial versus lateral, because then you got to do this, okay? All right, that horse is dead. I beat it. So lateral drift of the toes and plantar subluxation of the metatarsal heads. Lateral drift of the toes. Okay, now we're in lower extremity. Is it okay to use medial and lateral? Yes, because nobody stands. I'm not going to do it because then you guys will take pictures. But nobody stands in weird positions. You don't have to do this or so. This is just how you stand. So you can think of things as medial and lateral. That makes sense, right? And then plantar versus dorsal. Well, hopefully we understand that by now, right? Plantar is the bottom surface. It's the surface that comes in contact with the ground. And dorsal is the other one, okay? So understand these key descriptors when it comes to RA, upper extremity versus lower extremity, okay? There's a nice little picture there at the bottom showing those subcutaneous rheumatoid nodules. They can be found at the elbows and the ears. Excuse me. So it's at the elbows. You see those knobby nodules there? Are they painful or are they tender or non-tender? Non-tender. Okay? If they're tender, they may be something else. Are they erythematous? Are they warm? No. So again, don't confuse these with a pathology you'll get in the next block, which is olecranon bursitis, for example. Olecranon, right? The pointy part here of your elbow. Okay? It's kind of near where the nodules would be, right? But if it's red, swollen, and angry, is that a subcutaneous nodule? No. Does that have anything to do with RA? No. So don't get those mixed up in your mind. Questions about this slide? I'm sure people have stars and butterflies drawn around this slide by now. Okay, but I'm just telling you, this is something you're going to have to burn into your mind somehow. Hopefully the ulnar radial thing helps you. Okay, so as astute clinicians, you're always going to get radiographs. You're going to get AP lateral and oblique films because it's upper extremity, right? Of the wrist. If you need to zone in on the fingers, are you going to get dedicated finger views too? Yes. Everybody understands that a wrist x-ray is zoomed in on the center of the wrist, right? So it may not necessarily get all the fingers to the level of detail you're looking for, okay? I'll leave that alone for now. We'll talk more about that next week. So common signs on radiographs. Another one that you have to key in on. Osteopenia. Did we say anything about osteopenia in osteoarthritis?
No.
Nothing. Okay? Did we say anything about bony erosions when we were talking about osteoarthritis? Nothing. And I already talked to you guys about the fact that this is symmetric, okay? So that's an important key factor here, okay? And there also is malalignment. Can you have malalignment in osteoarthritis? Yes, but usually that's more end stage, okay? So that one is not necessarily as specific, right, as the other ones are, okay? Lateral flexion extension views of the cervical spine, we talked about that before. That's to denote that atlantoaxial relationship between C1 and C2 and see if there is any instability there. What's the ligament that gets eaten away by the rheumatoid arthritis that I described earlier? Odontoid ligaments. They get chewed up, eaten up, inflammatory process, okay? So now we get into the labs, okay? This is a sticking point every semester, okay? Because what's taught is not different, but how it's asked is different. I'm not a pathologist. I am not an internal medicine doctor. I literally want to know, does this patient have RA or not? Okay? So if you want to know, then you're talking about things like specificity and sensitivity, okay? Inflammatory markers, let's start with that one. ESR, CRP. So when you talk about an erythrocyte sedimentation rate, which is an ESR, right? Okay? C-reactive protein, which is CRP, are those specific or non-specific? Non-specific. So you'll get that for most conditions that you're concerned about ruling out infection or inflammation, right? But does that tell you the diagnosis necessarily? No. It can tell you to what extent the systemic inflammation is, right? Especially if you see a trend in upward progression of those levels, okay? And we'll talk more about that when we get into certain pathologies, but like if we're trending infection, we may get these labs, okay? And then as we're treating the patient, then we get repeat labs and we can see whether those CRP and ESR levels are going up or going down in response to our treatment. Does that make sense? Okay, now we get into the stuff for RA though. So, Jesus, it's called rheumatoid factor. What do you think that's for? Right? So, okay. So, but only 75 to 95% of the patients will have that specificity. Okay, so then now you've ruled out necessarily who doesn't have it. Does that make sense of what I said earlier? Okay, but then you get an anti-CCP. I'm not going to say that word, right? Anti-cyclic citrullonated. Okay, yeah, we all know what that is. Okay, but the anti-CCP that we get into more sensitivity than RA, right? And more specific as well. We good with that? So if a test question were to ask you something like on pants, you would give a test question that says, which ones are more useful in diagnosing people with RA versus, let's say, OA? Then you're looking for it. Does it say RF on there, rheumatoid factor, and anti-CCP anywhere in there? And then, of course, they're going to give you combinations of them, right? So you need to know how these differ and how they relate to each other. Make sense? You guys had this already in pathology, correct? Many moons ago, seems like years ago. Okay.
I think this was in lab.
Lab?
Some markers, but not these.
Not these? Okay. All right. And cool. Like I said, I'm not a laboratory guy, but I can tell you that this is stuff you need to know. So let's get into it. If there's questions about it after we talk to it today, we'll get into it again tomorrow. Ma'am.
So the RF is marked by ruling out and
So let's go back to what I said earlier. So is specificity more for true negatives or true positives?
True negatives.
True negatives, right? So when we talk about specificity, we're trying to get a true negative, meaning it tells us who doesn't have it. Okay? Because in certain systemic conditions, RF can be positive. Okay, pause for effect. So then when we do the anti-CCP, is that true positive or true negative?
True positive.
True positive. So then we got a true negative ruled out, meaning they were RF positive, but they're also anti-CCP positive, which means we have excluded other conditions and now zeroed in more on the fact that they have rheumatoid arthritis. Did I answer your question? Okay. I know that probably still doesn't make sense to some people. I get it. You're just going to have to sit down, write it out, think about it, look at it again, step away from it, look at it again. Because can you have RF positive for patients that have ankylosing spondylitis? Yes, you can. But then if you get an anti-CCP, and that was in your differential, now the anti-CCP is positive, you're like, oh wait, no, I don't think it's ankylosing spondylitis anymore. I think now it's actually RA. Because we'll get to it later in ankylosing spondylitis, but there's another test you do for that one. Okay? So you take all these tests, and it's not one test. You take all these tests and how, is this one positive, is this one negative? And you put them together, and that's how you decide what's what between all those systemic inflammatory conditions. Okay? Are we good for now? And we'll hit it again, I promise. Okay? So, but if you have both RF and anti-CCP, 55% sensitivity and 97% specificity. Okay, so is that pretty good? It's pretty good. Is any test 100% though?
No.
No. Okay? That's what I'm telling you. There's no such thing as the perfect test when it comes to some of these inflammatory conditions because there's a lot of crossover, okay? Platelet counts are basically useless, but the one thing you should know is that in an inflammatory flare, because these people can have different days, right? Especially if they're on medications, where some days are better than others, right? So as it tells you there, platelet counts are typically elevated in patients with an acute flare, but may be normal or marginally elevated in patients that don't have an acute flare. So if it's just any old day, again, the platelet count doesn't really tell you much. Okay, makes sense? Are we good with the last for now? Okay, so what's the mainstay, again, discussing non-operative treatments, right? What's the mainstay for rheumatoid arthritis? What does the term DMARD stand for? Disease-modifying anti-rheumatic drugs. So do we think we want to consider using those drugs potentially?
Sure.
Yes, it's at its own class, right? And then you have things like biologics, TNF inhibitors, okay? So those two things at the top there are focused in on treating the actual inflammatory systemic disease. Does analgesics do anything to treat the anti-inflammatory systemic pathology?
No.
No. So that's why I want you to get clear in your mind. When we're talking about those first two up there, see how there's a number one and a number two? Those are the mainstays. Have you guys heard that term before, mainstays? Okay, those are the main players when it comes to selection of medications, right? Because those are actually going to treat the underlying systemic inflammatory process. The other players at the bottom, does that treat anything? No, it treats pain and inflammation, but does it treat the actual pathology?
No.
No, it does not. Okay, so think of that in your mind. Make your notes right now. Keep those clear in your head. Mainstays of treatment, DMARDs, the TNF inhibitors, right? The biologics. And then the ones at the bottom are supportive, adjunctive treatment modalities or treatment selections, okay? Analgesics, both oral and topical. When we talk about oral, it's the same stuff we talked about yesterday, Tylenol, Motrin, things like that. When we talk about, when we talk about topical, what kind of stuff are we talking about there? Lidocaine patches, right? What was that? Voltaren gel, perfect. You guys have obviously seen your primary care for a back sprain or a knee sprain, right? They give you that stuff. So Voltaren gel, it helps with some stuff, right? Lidocaine patches, it helps as long as the lidocaine's active, and then once they wear out, okay? But in this type of disease process, they're very commonly used, okay? Because unfortunately, what else do you got, right? You gotta give them some relief, okay? But again, you'll be prescribing this stuff in volume. Okay? The pharmacy may run out if you have a lot of rheumatoid arthritis patients at your duty station. So, and steroids. So let me just clarify this. Will steroids, corticosteroid injections into any joint, treat the systemic inflammatory process? No. The key term is systemic, right? It'll treat the inflammation in the joint, but not the systemic inflammatory process and not the underlying cause of the actual disease itself. Good to go with that? Okay, I'd beat 2 horses to death. Okay, don't do what this person's doing in this top picture and do an injection with no gloves on, please. Thank you. I still have to take that out of the slide deck. So when we talk about rheumatoid arthritis, so this is one of those things, again, if it gets to a point where it's end-stage rheumatoid arthritis, what are our 2 options? Arthroplasty and arthrodesis. Okay, here we are. Okay, total joint arthroplasty or arthrodesis, end-stage arthritis. Everybody has at least somewhere in your studies or somewhere in your life has seen these pictures. It denotes the prosthetics are used for joint replacements. Everybody would agree that's a hip, right? Yeah, and then the one on the right is a knee. Okay, so they're different prosthetics, right? Okay, I'm not going to go into surgical techniques with you guys, don't worry. I just want to make sure we're on the same page. What is a synovectomy and tenosynovectomy? Well, that's what it sounds like. Sometimes you got to start whacking stuff. Okay, you go in there and you take away that capsule, or you take away the capsule and the tendons and ligaments that are around there to relieve those contractures. You guys remember how we talked about radial deviation of the wrist and ulnar deviation of the fingers? Right? If they get fixed contractures, sometimes they'll go in there and do these procedures where they do a synovectomy / tenosynovectomy and try to release some of that. Okay? So the patient at least has some more, I should say less discomfort. Good to go? Okay, awesome. Risk of treatment, adverse outcomes of treatment. Again, that's the terminology your book uses. But what's the bad stuff that can happen, right? So always the risk with the NSAIDs, okay? Was renal on there for systemic symptoms, renal pathology?
Yes.
It was. So these are patients that maybe you can't necessarily give them high dose NSAIDs because of their renal status. Good to go? Okay, another one is infection risks. When patients have autoimmune conditions, are they immune compromised? Yes. When they have systemic autoimmune manifestations, they can be immune compromised. So their risk of infection goes up, right? So do you think that these are patients that we may have to be more careful about counseling on potential surgical indications? Yes, because they may not recover like you or I would. Definitely not like I would. Yeah, so post-op complications, we won't get into those. But just understand, again, the concern's always for infection. So what if you have a rheumatoid patient with diabetes? It's like the cross, right? It's like, oh God, get that patient away from me, right? Because I don't know. I just don't know. But we got to do something to help them. But I'm just saying surgery may not be the best, right? Best option. So questions about all that stuff. So was that a seronegative arthropathy? Seropositive arthropathy. So now we're going to cross a bridge after we go on a break. Okay? Let's come back. How much break do you guys need? If I say top of the hour, we're good? Woo! Now you guys asked me no questions yesterday, and today you got all the questions. That's good. You weren't awake? Okay. Honesty. I appreciate honesty. I don't know how frosty I was either, but I was here. So, all right. You guys are asking very good questions, okay? Now just understand that when it comes to questions, you may not be ready to receive my answer. Does that make sense? So we will get into pathologies and systemic processes and microvascular changes and things like that. But we will start with a kind of an out view, and then we will cone in. And as we cone in and go deeper and deeper and deeper into, let's say, like intervertebral pathology, then your mind will start zeroing in as well. Does that make sense? That's why we have to cover these topics as we go. We're going to build on each other. Good to go? Okay, so don't feel frustrated by that. Keep pushing. Okay. If you have more questions, I know I had to turn some people away to get started, but if you have more questions, we'll hit it at the end, okay? All right, so now we're talking about seronegative spondyloarthropathies. All right? Seronegative. Okay? Why? Because they're negative for RF. Remember I told you earlier, if RF is negative, will you order an anti-CCP? And you're concerned about RA? Yes, you still will. Because again, is there a crossover? There is crossover, guys. You guys know this. There's such a thing as lab panels. But these specific conditions, if you're given a PAN scenario that tells you that the patient is RF negative, do you think they're going to get that tricky?
No.
No, that just means you gotta start trying to zero in on what the other labs are that we'll get into. Okay, makes sense? They can't do that to you guys, right? I won't do it to you guys, because that's just not fair to you. There's just too much there. The axial skeleton is commonly involved, okay? Axial skeleton, right, so that midline stuff, okay? Good to go? Patients often report back pain. Well, I got back pain, I'm sure half the class has back pain, right? So what does that tell you? Nothing. That's why back pain is a symptom, not a diagnosis. Do not diagnose your patient with back pain. That is a symptom. You guys are gonna hear me say that a million times. So now, what we zero in on is ankylosing spondylitis. Okay? Spondylitis. Spondy, meaning referring to the spine or vertebrae, if you want to be fancy. But also the itis, right? So there's an inflammatory process. Are we good with that? So this is not spondylosis. Spondylosis is degenerative. This is inflammatory. So then we zero in on a couple things on top of ankylosing spondylitis. One of them is reactive arthritis, okay? Otherwise known as Reiter syndrome. You guys heard the term can't see, can't pee, can't climb a tree? Okay? Did everybody go north and south? That's okay, well, we're all on the same page. Okay? It has multiple systemic pathologies. Okay, so that's Reiter syndrome. Psoriatic arthritis, we don't really get into it that deep, but just understand that that's into your differential diagnosis. That's probably something that's more appropriate for derm discussion, because do I see patients with psoriatic arthritis? No. Hopefully not. Arthritis with irritable bowel disease. Can you have joint pains that correspond with IBS, IBD, irritable bowel disease? You can. Is that necessarily an orthopedic condition? No. But to be fair to you guys in your learning process, we're trying to make sure you guys have a good understanding of a differential diagnosis. You guys see why those are on there now? Okay. Will you see those on my test questions? No. What are the ones that I'm going to be asking you about? Ankylosing spondylitis, and can't see, can't pee, can't climb a tree. Okay? You need to know those. Okay? Ankylosing spondylitis, again, affects the axial skeleton. It causes sacroiliitis and kyphosis. Sacroiliitis. Where's the sacrum? Oh, my sciatica. Right? So everyone's going like this. Right? So that's your sacrum. That's a sacroiliitis. Okay? And kyphosis. Kyphosis is that curvature, right? You guys see that picture on the right there? How that patient stooped down like this? Okay? Is that something where they can just rise from that position after the disease has been there for a long time? No. So they're in a kyphotic position. Okay? So it's a progressive deformity, essentially. Remember how we talked about deformities? This is one of them. Okay? They usually occur second to third decade of life, 3 times more common in men. So you're given a clinical scenario, right? What decade? Second to third. So let's say 28-year-old male presents with 4-month history of lower back pain. Are you thinking of RA? Not necessarily. Still chance. Remember, it's 3 to 1 with RA. It's still possible. But then it says that they have sacroiliitis and kyphosis somehow in that scenario. You have now just excluded RA and are more focused on AS, ankylosing spondylitis. Make sense? This is how your mind needs to start thinking. Okay, it's a shift, right? 92% HLA-B27 positive. So you got RF, okay, and it was positive. Then you got an anti-CCP and it was negative. And then you got an HLA-B27 and it was positive. What's your diagnosis now?
Ankylosing spondylitis.
Ankylosing spondylitis. Boom. Hopefully that tied it all together from your question earlier, ma'am. So that's how these things can manifest. These things can differentiate. Because all those tests, you put them together. You don't just look at one test in isolation. Are we good? Okay, so what are some of the itises that can occur as well? Uveitis, iritis, aortitis, cardiac conduction abnormalities. Okay, that's that nodes, all that stuff in the heart that you guys are going to get neck deep into soon. Okay? But just understand, does this also have systemic manifestations? Yes. So look at the clinical scenario you're given. Okay? What's the distribution of this again? axial. So if it tells you that the patient has radial deviation of the wrist and ulnar deviation of the fingers, are you zeroed in on ankylosing spondylitis? No. See the difference? Okay, good to go. So now we've shifted. Excuse me, let me go back. Any questions about ankylosing spondylitis? Okay. I'm purposely slowed down today because these are topics that I want to make sure you understand. So now we can speed up a little bit because reactive arthritis, this is caused by something, GI-GU related. Sexually transmitted infections, things of this nature, okay? So 63 to 96% HLA-B27 positive. Okay, so what does that tell you then? It's 63 to 96% HLA-B27. Does it say anything on here about sacroiliitis or kyphosis? So there's your differentiating factor, okay? But they can have systemic symptoms, right? Can't see, so what is that one? That's the uveitis, conjunctivitis, right? Can't pee, that's the urethritis. And can't climb a tree, that's the arthritis. We good with that? Okay, so that's how you need to differentiate that, okay? Am I gonna test you on treatments for this? No. Will you potentially get asked about this in a clinical scenario in OSCEs? Yes, okay? STIs, that's sexually transmitted infections and dysenteric disease, are more common 2 to 6 weeks before onset of joint pain. So that's where you get to talk about what? Chlamydia and gonorrhea. Do they very common exist together?
Yes.
And that's why we treat them together, right? Regardless. Presumptive treatment, okay? But then you start talking about those other bugs on there. Shigella, is that an STI? No. I know you guys are in infectious disease now, so I'm just trying to get the brain thinking. Salmonella, definitely not, right? Yersinia, Clostridium, difficile, and Campylobacter? No. Okay, so again, those are not the STIs, those are the GU. And, excuse me, those are the GI bugs, if you will. Okay? Are we good? All right. Psoriatic arthritis, again, not too much that I would test you on this. Is there dermatological manifestations? Yes. That's how this one differs, okay? So with psoriatic arthritis, a lot of times you have psoriasis. So therefore, the scenario will lead you in that direction. So read the question when you're taking pants and see, are there any dermatological manifestations being described to me, okay? 18 to 24% of patients with psoriasis in North America and Europe, I mean, good on them for being able to quantify that, but I doubt that's accurate. Okay, but is it common? So that means that a quarter of the population has it, upwards of a quarter of the patient population, right? So you might see it, okay? Male equal to female, so there's no preponderance in one population, one sex versus the other. Age of onset, late 30s, okay? I don't know, that's very non-specific, right? 5 patterns of psoriatic arthritis. DIP joint arthritis. Does RA involve the DIP joints? No. There you go, you're welcome. I just pointed out how this one's different, right? So, asymmetric oligoarthritis. Is RA symmetric or asymmetric? Okay, there we go. Symmetric polyarthritis, okay? So, again, differentiating between what's symmetric and what's not. Are we good with that? Okay. Arthritis mutilans, okay? So that basically means that there is a process that occurs because this is an inflammatory systemic, right? It's just seronegative. Everybody understand that? Okay, so that's that arthritis mutilans. Well, you have destructive forces there. Is there an erosive component to it? Yes, but not to the extent of RA, okay? Sacroiliitis, so that one does cross over a little bit with ankylosing spondylitis, right? But you would agree that the distribution of the patients that typically get ankylosing spondylitis is different. Okay, are we good with that? Is there kyphosis in psoriatic arthritis? So there's one differentiating factor. So this is how I want you guys to study, okay? Use your reading sheets, study like this. I'm trying to give you some insight into how to study. DIP joint involvement plus absence of RA nodules differentiates systemic polyarthritis from rheumatoid arthritis. Okay, that's kind of summing it up. This is what your book says. Okay, we good with that? Okay. So arthritis associated with inflammatory bowel disease. So then we talk mainly about ulcerative colitis and Crohn's disease, right? So the incidence is 10 to 20% more common in patients with which one? Is it Crohn's or is it?
Crohn's.
Crohn's, yes. Sorry, I trouble off there. Yes, so just understand that it's even within that 10 to 20%, excuse me, even within that subpopulation, it's more likely in Crohn's. Good to go? Okay. 50 to 70% are HLA-B27 positive. What does that tell you then? Then you have to make a diagnosis based on the other factors as well. Okay? So do you think that HLA-B27 is very sensitive for this condition?
Yeah.
True positive.
Think about it for a second.
No.
No, it's not, right? So it doesn't tell you who has it, because that's what sensitivity is, right? Specificity is for telling you who doesn't have it. I know, you guys are gonna go home and be like, man, he just keeps saying it over and over. I just don't get it. Just trust me on this. This is something you guys are gonna look over many times. You guys are doing your research projects too, right? So you talk about specificity and sensitivity in your research projects. Well, some of you are doing your research projects from what I can tell, that response over there. But, okay, so because that comes into role with research as well. Okay, anyways, moving on. So seronegative spondyloarthropathies, clinical symptoms. This is a kind of a synopsis here of everything we just talked about. Okay, as you peruse that real quick and you're looking it over, does it hopefully make a little more sense now? Clear as mud? Okay, this is how, again, you gotta start breaking these things down. Okay, does psoriatic arthritis, is that the only one on there that has cutaneous lesions? Yes. You see that, right? Yeah, the answer is yes. Okay. All right, I'm not gonna linger there. So with ankylosing spondylitis, that's the only one we talked about that has that kyphosis, right? So that's that deformity, right? So that's the one that's gonna have the limited spine range of motion. Okay, Faber test. Here we get into a special test again, right? Faber test, we're gonna talk more as well about it when we start talking about hip exams. But Faber is in, the letters are all in capital, right? Flexion, abduction, external rotation. Flexion, abduction, external rotation. So is that the figure 4 test? It is, right? Is there a possibility on pants? Sorry, I heard something. On pants that they'll describe the test and not call it a Faber test? Yes. So just get that in your head, kind of what it looks like and how you would tell a patient to do it if you weren't actually putting him in that position. That'll help you, okay? There's our second special test. Enthesitis, okay? That's a specific inflammation where what? Tendons or ligaments attached to bones, okay? Hand swelling, inflammation, nail abnormalities. Do we see that sometimes in ankylosing spondylitis? We do. Okay, but that's not those cutaneous lesions. That's literally just some nail, if you will, defects. Okay? Good to go? You see that test that he's doing right there where he's putting the measuring tape on the patient? Right here? Right here? Okay, and he's having him bend forward. What do you think that test is called? The Adam Ford bend test. Adam Ford bend test. We'll go through that in our lab next week. Okay? Adam Ford bend test. Is that test also used for scoliosis and other checks? It is. Okay? But again, this is where we introduce this. Everybody understands this attachment point here at the bottom? Here at the bottom, where we're talking about enthesitis. So if someone were to describe to you that they had inflammation at the insertion point of a ligament, you understand that that's enthesitis and not just arthritis, right? Okay, good to go? Yeah, moving on. Okay, imaging, always gonna get imaging. In psoriasis, you're gonna see resorption of phalanges, bone reaction to DIPs. Do you have involvement again in RA? No. Is there necessarily the erosive stuff? No, that's more the reabsorption. Okay, so again, you're like, well, what's the difference, Davlos? Okay, I was trying to explain to you. In RA, it's completely destructive, okay? In ankylosing spondylitis, this picture here is what they call bamboo spine. Have you guys heard that term yet?
Yes.
Okay, yeah, so bamboo spine. So basically the spine starts fusing, okay? And that's where you get that loss of range of motion. Does that make sense? So is it destructive in the sense that it obliterates the joints, the intervertebral spaces? It does, but it doesn't erode them like RA does. And bamboo spine is specific to ankylosing spondylitis. Good to go? Right? Narrowing of the SI joints, bamboo spine with preserved disc spaces. So it obliterates those margins. I just explained to somebody right now. So if you look at these margins here, you see where those arrows are? Right on that point, right? Those are called end plates. You see how the end plates all fused together? So one on top of the other is perfectly on top of the next one. But it looks like the actual spaces in between still look symmetric when you go from top to bottom. Everybody picture what I'm saying?
Mm.
Okay. What that is getting to the fact that the disc spaces are still preserved. So it's like the discs themselves in those spaces have been encapsulated. Make sense? Questions about that? I don't think I've ever explained that before. So, yeah, but that's what's occurring. Okay. Laboratory again, negative RF ANA. ANA we don't get too much into. We'll save that for a different class, okay? But is it positive HLA-B27? Boom, that's your one. Bamboo spine, HLA-B27. Look at the answers on the PANS test. Find ankylosing spondylitis, circle it, check it, whatever. Now it's all computer, right? So select that answer and move on to your next question, okay? Why would you obtain your analysis though? Because what's in your differential? Reiter syndrome, okay? ERC, CRP, ESR, are they helpful? They're helpful in staging and kind of trending, but not necessarily in making the diagnosis. Make sense? But if you're treating somebody for Reiter syndrome, do you think you might repeat those labs and see if they're improving?
Yes.
Yes. Okay. Good to go? That's it. So now we start talking about some medications. What's an NSAID that's described here with ankylosing spondylitis that we have yet to talk about? Indomethacin. Okay? Indomethacin is a big gun NSAID that we use a lot of times for things like gout. Yes. What heart condition you guys may know about? Pericarditis. Things like that, right? So this is a big gun. This is not something you're going to give somebody for, take this, change your socks, rub some dirt in it. No, you're not going to do that, right? So just understanding this is something very specific to this diagnosis, okay? Make sense? Do you give this for Reiter syndrome? No, not necessarily. You can, depends. But you got to treat the infection, right? Reiter syndrome is an infection. Make sense? So is there any antibiotics listed on there? No, I'm not going to ask you those questions. This is not that class, okay? Psoriatic arthritis, DMARDs, phototherapy for dermatological manifestations. What is phototherapy? That's literally what it sounds like, laser show, right? These are fancy equipment they use to blast these patches, these psoriatic patches all over the patient's body, okay? Good to go? Inflammatory bowel disease, well, it's inflammatory bowel, treat the bowel. That's as far as I want to get into that. Yeah. General surgery does bowels, we do not. Okay, so this really has no play in orthopedics, but treat the cause. So operative, what are our options for operative for any of these conditions? If it gets bad enough? Arthroplasty, arthrodesis, right? Okay, so are you going to send all these patients to orthopedics? Not necessarily, okay? Are you going to send them to an eye doctor if they have eye manifestations? Yes. Are you going to send them to a bowel doctor if they have bowel manifestations? Yes. Pulmonology if they have respiratory manifestations, airway manifestations, pulmonary manifestations? Yes. If they have dermatological stuff, are they going to send them to a dermatologist? Yes. So what does that mean? You guys, as the primary care managers, may be managing a lot of referrals for one patient. Are they always going to come back to you?
Yes.
Yeah, they will. You're the gatekeeper, if you will. Yeah, you thought you were gonna say no and get away with it, right? They will come back to you, and then it's your job to see where they're at with all these avenues of attack. Make sense? But that's why when we were talking about it, we talked about how it was a systemic process. Right? It's a systemic inflammatory disease. Now the thing we need to differentiate is it RF positive, RF negative. So again, CO positive, CO negative. And what kind of manifestations do they have as far as spinal involvement, sacral involvement, right? Sacroiliitis, kyphosis. Do they have dermatological considerations, right? Manifestations, excuse me. So that's how you differentiate these, okay? Make sense? All right, I don't want to cut into your lunch. I appreciate your attention today. I'll answer any questions you guys have.